Okay, it looks like our number's a bit more stable. So it is 2 p.m. on the hour, so I guess we can get started with our session this afternoon. Well, hello and welcome to today's webinar on CODA, Transforming Nutrition Support Through Scalable Digital Solutions. We're delighted to have you here with us to join us on the session. Just a quick note, the webinar is being recorded, so we can share this with colleagues who are not able to join us live for today. Also, just to help us get to know each other as we go through the session, please feel free to introduce yourself in the chat. So that is your name, where you're joining us from, and also your role. As always, a few housekeeping items. Please keep your mics and your cameras off for now to help with bandwidth. If you have any questions for the presenters, please use the Q&A box, which should you navigate to the bottom of your screen, it should be next to the globe. We also have a dedicated Q&A session for the after the presentation, so then on we'll deal with any questions that come up. And for any other general views and comments, please feel free to use the chat. So if we move on to the next slide. Thank you, Miriam. So yes, in the next slide, if you'd prefer to follow the session in French, you can click on the globe icon at the very bottom of the screen and select French from there so you can switch the language. A very, very big thank you to Seprotec, who's providing today's French interpretation, and special mention to Alessandra Alviraz, who's supporting us live. And then if we go to the next slide, we also wanted to acknowledge the different partners who allow us to make these kinds of events possible. So this webinar is brought to you through a collaboration between the Global Nutrition Cluster and the World Food Programme. So we'd like to take a moment to acknowledge the different donors who've supported us in making contributions so this type sessions like this can actually take place. So then in our next slide, I would then kick off, since this is our intro, to which I'll then say good afternoon and welcome. My name is Tavimba Nashe, and I will be facilitating this session as part of the World Food Programme Nutrition Knowledge Management and Learning team, where I'm the Nutrition Integration, Learning and Documentation Officer. So in the next slide, I also show you that I have not come alone this afternoon. I've joined by a number of my colleagues who I'll give a brief introduction. So we have Linda Keys, who's the Chief of Learning and Innovation within WFP Nutrition. We also have Hajra Hafiz-ur-Rahman, who's the Team Lead for Monitoring, Evaluation, Research, Learning and Innovations for Nutrition. Then we also have Mohammed Almala, who's the Nutrition Program Officer in WFP South Sudan. We also have Kasi Abdul-Latif Tuahi, who is also the Team Lead for Nutrition Digital Innovations with WFP Nutrition. So in slide 6, which is the next one, I guess answers the question of why are we here today? So for this session, it's an opportunity for us to explore how digital innovations like CODA are helping us in terms of reshaping nutrition service delivery across World Food Programme operations. So over the next 40 minutes, we will understand what CODA is and how it works, look at its technical design and value proposition. We'll also explore how it's being applied in complex humanitarian settings. So that's where we'll bring in the experience from South Sudan. And finally, reflect on the lessons that have been learned from this experience and where to next. We hope that this session gives you practical insights and sparks what would say maybe ideas for how we can use digital tools to strengthen our work as nutrition practitioners. So with that, I'll hand over to Linda to kick us off. Over to you, Linda.
Great, thanks, Tav. Let me just see if I can get my video started. Doesn't seem to want to start. So I'm going to get started. Hopefully my video will start momentarily, but just given the time frame, I'll start speaking. So essentially, for the rest of I'm going to introduce CODA. CODA stands for Conditional On-Demand Assistance. However, I don't want you to remember what CODA stands for the rest of the presentation, or actually for the rest of the time frame. Because essentially when we talk about CODA, I want you to think about a scalable digital solution for wasting prevention and management. I'm having an issue with my computer. Can everybody, I can't tell whether people can hear me.
Linda, we can hear you. We can't see you, but maybe just keep your camera off if it's not working. Linda, we can't hear you.
Can you hear me now?
Yes, we can hear you now.
Okay, super. I just can't get the video to start. Anyway, so CODA stands for conditional on. It doesn't actually really represent what we're doing. CODA is really a scalable digital solution for wasting prevention and management. In 2018, WFP started piloted CODA to address operational and data quality challenges that we were facing. We piloted it and started the pilot in South Sudan, and we revised CODA in 2024 to be an open source an interoperable system for the management of wasting, prevention, and management. Next slide, please. Okay, so I think just because many of you are very familiar with this topic, I'll just do a quick intervention of the context that we're dealing with. Wasting prevalence remains a significant challenge in many of the countries where we work. There are persistent high levels of wasting in children and women, and that's stemming from a wide range of different factors and a combination of those factors. As a result, the management of wasting remains really a critical intervention. It prevents mortality and also has a big impact in terms of ensuring good health and learning, and it's also important for livelihood and resilience and crisis recovery. WFP came to CODA because we play a role in supporting more than 55 countries in terms of preparing and responding to malnutrition in humanitarian crisis. And we directly reach more than 30 million women and children each year with targeted support. Our experience has shown that timely and high quality data is really critical for effective decision-making in humanitarian response. And that's both for frontline workers, but also for governments and other actors in general. So it's around larger program planning, but it's also for a specific individual patient care and services. So we need accurate real-time information to track our progress, to identify bottlenecks, but also increasingly to prioritize resources where needs are greatest. Next slide. Okay, I can't see the next slide, but there it is. Great. So a number of data-related barriers to effective nutrition responses in emergencies are the following kind of. I think many of you are very familiar with stacks of fiches and big, thick registry books. So many of the systems, the data systems that we use in nutrition are still paper-based. And that has issues around fragmentation. They can be very prone to error, and it's also quite a slow process then for us to be able to manage the data when it's in a paper system. That also then leads to gaps in tracking. There can be weak follow-up for children. That means that we may have delays in decisions around supplies, the referrals, and also can limit some of our thinking in terms of scale up. In addition to that, I think one of the barriers that we face is that we often have we're often operating in different silos, where each of the different stakeholders may have their own systems, and that makes it more challenging to coordinate, to report consistently, and to sometimes also potentially double count some of the work that we're doing. So I think the need also is that because of the different factors that are leading to humanitarian crises, there's an increased need for real-time data in order to make these decisions, and then interoperable data in order to be able to ensure that we're managing the work we do across systems, and to ensure that that our service delivery and outcomes are being met. So what these different factors kind of brought us together to think and develop CODA. Next slide. So what exactly is CODA? And so I said earlier, basically, that when you hear CODA, you should really think something around a scalable digital solution for wasting prevention and management. And so what CODA really does is it's a real-time digital platform designed really to support wasting prevention and management, but it has potential for even more broadly, additional nutrition and health programs. It simplifies data tracking, and it helps us to monitor both severe and moderate wasting cases, but also prevention, and allows us to address critical challenges in data quality and field efficiency. Essentially, what CODA offers is better informed program decision-making and streamlined field operations, and it enables us to deliver impactful programs in humanitarian contexts, really helping to ensure that we're able to meet the different outcomes that we have identified or that we planned for, and helps us to think through how do we achieve efficient integrated programming. Next slide. So the value proposition of CODA has a number of different components. So first off, we're aiming to look at how do we have targeted nutrition support. So CODA 2.0, the new version that we have, which Cassie will talk a little bit about, uses smart algorithms to accurately help vulnerable women and children in need make sure that we have the right nutrition at the right time. We also have efficient data management. And there, in that for this, we're able to transition from paper-based methods to digital tools. That helps to improve the accuracy and efficiency for the health and nutrition workers on the ground. It reduces mistakes in delivery services. We also have an agnostic integration with data systems. So CODA is open source, which means that we can integrate the platform with other systems and other platforms which have been established in the health system, and therefore it reduces the need for multiple systems, and it allows us to scale fairly quickly without creating bottlenecks and compatibility issues. It provides near real-time data access, which means that we can facilitate informed decision-making on the ground. And it allows us to be proactive and deliver effective nutrition program. There's also quite a bit of efficiency and cost savings with CODA. Cassie will talk about that a little bit more specifically based on the learning that we have from South Sudan. But it does, in fact, allow us to save time and money. It's eco-friendly and proactive because we're reducing the environmental impact of our reporting. And it helps to predict better to predict and prevent malnutrition, and therefore, again, save resources and time. CODA also allows us to better coordinate and collaborate on nutrition because of the interoperability and the ability to track and deliver key information. We work more closely between WFP and UNICEF to look more comprehensively at an approach for nutrition management of wasting prevention and treatment. It's also for WFP a corporate solution and a digital public good. So it's really designed to identify and enable action on specific needs, and it aligns with WFP's internal controls and therefore helps us to strive to a digital good public good, ensuring that it adheres to open standards and respects privacy and other applicable laws. Next slide. Thanks. I'm going to hand it over to Cassie now, who's going to talk a little bit more about exactly how CODA works. Over to you, Cassie.
Thank you so very much, Linda, for such a comprehensive presentation, overview, and background on CODA. Hi, good afternoon, good morning, good evening, wherever you are, and thank you so much for joining. So basically, what you're seeing on the screen is a schematic representation of the setup of the treatment, waste management or treatment at the health facility level. CODA is a solution that encompasses end users who are the health extension workers or health workers, nutrition workers. And then also, of course, we have the backend solutions and whatever else we have that serves the remainder of us. So what you're seeing is a depiction of a typical wasting treatment program at a health facility. Looking at the various business processes, including registration, anthropometric, medical, and assistance, CODA, the application works completely offline. Like Linda said, it has very smart decision tree algorithms programmed into it to guide beneficiaries, ensuring that inclusion and exclusion criteria are very strict and in accordance with the country's IMAM protocol. So ensuring that we do not leave anyone behind or include anyone that is not supposed to be in the program. So these logics also help those health workers without adequate training to actually understand what next is supposed to be provided based on a number of characteristics that have been already programmed. So CODA essentially is not just collecting data, it is recording progress and making decisions for follow-up visits, and then also home visits that are required, and then referrals and linkages to other services, and so on and so forth. So it captures every single information that is required. So imagine the information powerhouse, the information data ecosystem we are building to better understand our nutrition programs based on all this data that we are collecting, and now as compared to traditional systems and the manual record keepings that we currently have. So CODA enables us to do this. So this whole process is at the health facility level, including determining the amount of assistance due a beneficiary, are done offline and they're automatic. For example, in the OTP program, where the amount of service, amount of supplies are determined by, for example, a number of factors, including the weight and the age of the child. CODA is programmed to actually do this kind of assistance determination offline. So when all this data is collected, we expect the data to be synchronized, transferred online, and then all the other consumption and transformation takes place, right? The process of extracting this, transforming this, and then loading it for our consumption then takes place online. Next slide, please. So where are we globally? Since we redeveloped CODA in 2023, we launched this current version of CODA in August last year in South Sudan. And currently, as we speak, we are in Nigeria and then Ethiopia too. Ethiopia, we just launched last week. And the interesting thing about the context is that CODA is adaptable to any kind of modality of or type of delivery assistance, from the continuum of care approach, where we have various countries implementing, to the new WHO guidelines that requires the inclusion of other criteria. All these adaptations have been made. I know my colleague Mohammed will talk more about where they are currently and how the program supports. So this current version of CODA, we have supports both OTP and then CSFP programs, that is SAM and MAM management, including also some elements of prevention and then supply chain. Now, this supply chain component I'd like to highlight is about the stock management aspect of CODA, which we are currently developing to ensure that we have visibility on the stock status of every single nutrition site where CODA is being implemented, ensuring that we get timely alerts on possible or potential stock out, and then we are able to replenish on time. We can actually, through the stock management feature, track the commodities by batch number, hence the expiry date. And in WFP terms, we have TDD, where terminal distribution dates of some of these supplies. We can actually tell which beneficiary from which community consumed what supplies. from tracking the batch number. Then we connect to the systems or organizational track and trace supply chain solution that closes the loop and helps us to understand supplies, consumption, and utilization in the field, including losses and then transfers of commodities. Next. So programmatically, I know Linda has talked about this already extensively, so I wouldn't go too much into it. But because of CODA, we are able to better improve the quality of the assurance of our programs, ensuring that protocol adherence, utilization of our commodities by integrating with other effective programs and linking beneficiaries, and then also ensuring that our processes at the health facility level are streamlined. There is no skipping and ignoring of other things, beneficiaries that are lost to follow up. We can reduce all of that. And then in terms of operational cost, the one-time capital expenditure on CODA may seem big, admittedly so. But the long-term maintenance cost is very, 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 very affordable, very cheap. I wouldn't say cheap, but quite low, and ensures that, long-term, when you compare it to the investment we make and the challenges from manual record keeping, we'll be saving substantial amount of money. CODA is being designed for a low code solutions that ensures that we can easily scale it up with a kind of technology because of the fact that we are building CODA with ODK forms within the application, so easily customizable. When we decentralize to the country office level, they can make any changes that they want when they want at the time of their choosing. So it is easy to scale. It is easy to hand over to government to maintain. So basically, we are building a solution that is sustainable. It can function with limited connectivity or no connectivity at all, and then power infrastructure. So this is South Sudan. South Sudan would give their experience on these things. Next slide, please. So like I was saying, we did some kind of simulation of 900 sites, and the cost of actually buying or producing manual record keeping forms and registers for beneficiary level record keeping, site level record keeping, and over a period of 5 years, and then investment in CODA. And we realized that the organizations will be saving of around $1.5 million if you are going to consider all these metrics and parameters that I just mentioned. Next slide, please. So for the benefit of, or in place of not being able to give you a demo of the tool, I'd like to just highlight the key components of CODA. So we have the mobile application. And what you can do with this mobile application is where the logic is, where the brain of the protocol has been, planted to guide the health workers to do this. It's not a solution for you to record how many children you admitted, how many discharged. No. CODA actually helps you to kind of ensure you stay to the protocol. And we are able to do front-end deduplication. So any data or any beneficiary whose record is already in the system, depending on the scale of the reference population in the system, you can actually deduplicate. You can identify beneficiaries that are duplicated. You can also do back-end database or data science deduplication on a web application. You can also have access to aggregated reports offline. With just a click of a button, CODA will generate with you every populated or aggregated number of each category of beneficiaries or data that you have captured, each data point, total number of beneficiaries admitted by sex and by age disaggregation, total number of those discharged, defaulted, absentees, and then for follow-up action list, beneficiaries that are not responding to treatment, you'll find a list at every single day, any beneficiary that is either not responding to treatment and requires home visit, or that has absented by one visit and so will require some kind of follow-up action. You find a list of all that, the names of beneficiaries who have defaulted, names of those who are absent, the names of those who are not responding to treatment, and non-respondents, those that have reached the maximum length of stay without recovery. So you find a list of all this for your volunteers or health extension workers to do this community follow-up. You can generate daily stock report to see your stock balances based on losses, transfers in, and receivables. You can have a daily screening report that brings together community screening activity, that's active case finding, and then passive screening at the facility level. Then we have an offline entity sharing. So where there's a population, that is large, and then multiple devices are used to collect data, you can transfer data from one device to the other and so on and so forth to ensure that all the devices have the same data at the end of the day. And all these things that I have mentioned happens completely offline. When the data is then synchronized to the web, we have the web application where beneficiary management happens. You can edit individual beneficiary data here. You can also do deduplication. You can also pretty much do everything, that helps you to understand which devices are being synchronized, which devices have not been synchronized, where data is being collected, whether sites are active. There's a lot you can do here on the web application. And this is in the back end where, for example, agencies like WFP or UNICEF, and then even our partners can actually monitor what happens on the field. So you can see the actual data that is collected on the devices at the beneficiary level, at the individual level. All this data can be processed and then for consumption in the analytics dashboard. Then the jewel in the crown is that we are able to connect to government systems. And the DHIS2 being the health management information platform for most governments, CODA was redeveloped purposely for this. Now, next slide, my final slide. So the advanced analytics that wasn't really possible, previously with this current traditional systems, are now very much possible. We are looking at predictive modeling, where default and relapse rates for weight and what trends can be measured. Correlation analysis, where we can look at the wash situation of the beneficiaries, their food security, disease, and then versus whether it influences malnutrition and so on and so forth. So it is actually massive in terms of average weight gain, average length of stay, and so on and so forth. So there are a lot of analysis that we can do with the kind of data that we are getting from CODA, because it is detailed and for all the spectrum in the malnutrition management cycle. I think this is so I'll hand over to my colleague Muhammad, who would give us I think basically I have talked about this in so many ways, so there'll be no need to go into this. But basically, the modular architecture aspect is one thing that is new in this new version of CODA. Over to you, Muhammad.
Thank you so much, Cassie. Hello, everyone. My name is Muhammad Al-Malla, and I am a nutrition officer focusing on information management and evidence generation for South Sudan, for WFP country office in South Sudan. So adding to what Cassie said, I think it's important. I would like to mention that South Sudan is the country where CODA actually co-created, to respond to the needs of South Sudan, especially due to the high burden of malnutrition in South Sudan. The current conventional ways of collecting our data, informing our program was not sufficient. So we needed to create a new innovation that responds to the high needs in South Sudan. I'm looking at the technical feature slide. I think Cassie wanted to mention a few things about CODA. The fact it is built on a modular architecture. When you open, in a simple term, when you open CODA application, you would see different forms that you fill, which is actually similar to what we do in the paper system. So we have a form for registration and then anthropometric medical assistance. So all those things are there in the system. CODA also was built in agnostic, using agnostic technology. So it doesn't require us to be bound to a specific supplier or service provider. So that actually what will lead to eventually make CODA an fully open source solution that everybody can use. So there is no need for a specific services or specific devices in order to deploy CODA in any country. The other thing is that CODA was built keeping in mind that it has to be customizable and adaptable to any changes. With this, I will go to our experience. Let me take one step backward to say why CODA was created in the first place. So in South Sudan, we had several issues when it comes to CODA to nutrition program implementation. Can we move to the next slide, please? Yeah. So the first one is the fact that the current information system is really insufficient when it comes to collecting quality data. That is one of the things that we wanted to address using CODA as a digital solution. The other thing, due to several factors, we noticed that we have high inclusion and exclusion errors. Some of them are because of human error. Some of them are done actually due to the fact that in South Sudan, we have high turnover in terms of health workers. So whenever somebody leaves, another person comes. So sometimes we don't have the ability to train the new staff on a timely fashion. So that's something that contributes also to high error in terms of treatment. So thus the adherence to the protocol was not always optimal. The other thing also that when we do any referral between the nutrition sites to the health facilities or even sometimes the community, that referral is a bit weak and we lose the continuum of care we aim to maintain all the time. Another aspect is that when we collect data usually collected and aggregated from sites, from site level, and then it goes to the county level, and then it goes to the state level. So we have several layers to pass until we get the data where we can use it to inform our programming. So, and sometimes by the time we get the data and clean it, sometimes it becomes outdated and difficult to correct or to correct any mistake or course correct when it comes to programming. The last thing that I would also like to mention is that people at the site level, they are overstretched in terms of the workload, and also on like the several reporting templates and registers that they need to fill. So they have like a register for every sub program and then the ration card. So it's it's really cumbersome when it comes to how the health workers are actually performing their way. With CODA, we replace everything on the table. With all those big registers, we replace it with one single device that they can use and they can perform all the reporting. Next slide, please. There is a small video that we'd like to play from our experience and how CODA is doing in South Sudan.
We'll just put the link in the chat so that you can watch it, and we'll move on for now.
All right. So knowing all those needs and why do we need CODA, the concept of creating a digital solution came like around 2018, where the country office conceptualized the need for a solution that digitizes the whole nutrition care process. And they started with a concept in collaboration with our cooperating partners, MEDIR and ACF. There was a bit of a slow start where we have instability and health workers had to do like double registration. Due to that fact, MEDIR dropped and then rejoined after we established some stability in the system. Later, just before COVID-19, we reached a stage where we achieved some sort of stability, and also we proved the concept and we could see potentials for using digital solution. After that, next slide, please. After that, we were tested for another thing when it comes to CODA. That was the time when COVID-19 hit. Well, we achieved the stability, but then COVID-19 hit, so we were tested for something else, which is the flexibility. When COVID-19 pandemic hit, we in South Sudan, we changed the protocol and we moved to using only MUAC to reduce the interaction between health workers and beneficiaries. So that change also was reflected in CODA. So the protocol itself and the tools that we use in CODA was adjusted accordingly. At that time, we had CODA rolled out in 30 sites. And then again, we have seen potentials for its impact on the operation. In 2020, we had an important letter of agreement with Ministry of Health in order to make CODA like or adjust and give the ownership of CODA to the country office and also to the partners in order to ensure the sustainability of the product. And then in 2023, we did a review. Can we move to the next slide? Okay, well, so in 2023, we had an internal review of CODA, which showed us several lessons and several things to inform CODA implementation, things related to improving CODA and ensuring that it is actually agnostic and everybody can use it, and also in order to ensure that CODA is usable by other partners, it has to answer to the need of people on the ground. So basically, to ensure that the health facility workers are using CODA and finding it, appropriate system that can help them do their duty. Where we are now in terms of CODA in South Sudan. Currently, after the release of the new version of CODA, that was 2024, we rolled it out in few number of sites and then we scaled it up. We proved that CODA is now stronger, smarter, and it's ready to kick out. In the current program implementation, we also recognize that the importance of collecting quality data for the new WHO guideline. And that's why we incorporated that. And actually, CODA is the system that is being used to collect, in facilities where the new WHO guideline will be piloted. At the moment, I'm talking to you from Awil, one of the field offices in South Sudan, where the new WHO guideline will be piloted, and we have the pre-tests starting tomorrow. We will use CODA. We are currently, in terms of number of sites, we are currently in around 86 sites at the moment. We're expecting to reach 200 sites very soon. The training is currently underway. So by end of August, we'll have CODA up and running in 200 sites, where in those 200 sites, we have around 300,000 beneficiaries served per year. That is the caseload. And by the way, this caseload includes TSFP for children, TSFP for PBW. By TSFP, the Targeted Supplementary Feeding Program, which addresses moderate acute malnutrition, and also we have the OTP. We are going also to include modules related to prevention, and as Cassie mentioned, the stock management. So all those components are going to be incorporated in CODA. Can we move to next slide? So between 2021 and 2024, and based on the review that we did in 23, we have seen that CODA improved the adherence to the protocol and reduced the errors. And that was proven in from our observation from the field, where we could if somebody is using CODA, actually they cannot deviate from the protocol. Whereas in the paper system, we have spotted so many instances where beneficiaries, for example, don't follow the protocol 100%, or sometimes because they are under pressure from the beneficiary or something, they might deviate from the protocol. We have seen also that the service time reduced from 19 minutes to around 4 minutes after the health workers get used to using CODA. That actually contributed to reducing the time needed to capture the data, submitting the reports, etc. So that was something that was appreciated by the health workers. So they no longer need to fill multiple registers and multiple forms, and then later they need to consolidate and submit. So everything was really a matter of a click of a button. In terms of cost of beneficiary, at the beginning, we noticed that the cost of beneficiary was high. However, that was due to the fact we had CODA only running in around 30 sites. Now with the plan, and actually with the very soon we'll have CODA in 200 sites. That definitely is going to drop significantly. And we are aiming to bring CODA costs to exactly or even lower than the cost of the paper register. So that is something that we are aiming for. The most important thing is by using CODA so far is the fact that we identified like the big gaps that we have in the current nutrition information system, and all those problems that keep adding up from the data collection at the beginning and later on with the consolidation. So all those gaps, we identified where they are, and CODA managed to answer all those questions, especially when it comes to collecting quality data at the individual level versus the nutrition information system, the current one, the paperwork, which is just aggregate data. We don't know how many people are going into repeated cycles, how many people are defaulters, how many people are double dipping or registered in multiple sites. So all those problems are not possible, simply not possible to capture the nutrition information system, the paper-based nutrition information system, and CODA can address those issues efficiently. Can we go to the next slide? Currently, as I said, I'm currently in a wheel where we have the new WHO guideline piloted, and CODA was selected to be used and recommended to be used when we are doing this pilot because of the need to have quality data that will help us in actually generating evidence related to the adoption of the new WHO guideline, especially also for the fact that South Sudan is one of the few countries, the forerunners forerunners of the countries that are implementing the new WHO guidelines. So we are sure that other countries are actually eager to learn from our experience. So we wanted to ensure that we are getting quality data that we can that can feed into our knowledge management and experience sharing that will contribute to the global improvement of nutrition and addressing of wasting. So this is my last slide on the lessons that we learned from our implementation. The first lesson is that the need for having any solution actually co-created with the stakeholders and the users. That's something that we learned, and was evident when we were developing CODA. It's sometimes easy for us when we are, technical people sometimes can easily create something that answers their own question, but does not necessarily answer the needs that are there on the ground. So that's why we had several consultations with the beneficiaries, with the front liners to see how CODA is helping them. The other thing is that definitely any system that we build should have a level of flexibility, because we know for sure that protocols and guidelines keep updated, keep changed, and setting the system rigid is actually a recipe for failure. So that's why it's important to have that flexibility. And for CODA, it's built actually on a system that is commonly used in other platforms, which is anybody uses ODK, and ODK can actually start building their own form and use it with CODA. That is something important. And whenever we are transitioning from a solution from paper-based to digital solution, we need a bit of time. We need a bit of training. However, that training and capacity building can actually is really fast. And I could say, like from my experience last week, we trained around 100 health workers. The training on CODA was 2 days. On the first day, we introduced CODA to them. Some people actually did not have much interaction with the smartphones and these tools. On the next day, I could see that people are just picking it up, and it's just becoming like a a second nature for them. It's becoming, I told them, CODA will be your WhatsApp for nutrition programming. So people picked it up very well, and that was something positive. The other thing that we learned is the partnership with different stakeholders, whether they are other cooperating partners, the Ministry of Health or government counterpart. Involving them from the beginning is always important, just to ensure that we are addressing the needs in the country, and also we get their buy-in, and they can also, at some point, we hope that we will move these systems to the government part, and they can sustain it and keep it up and running. The fact that CODA, as I said, is an open source is really a plus. It doesn't require any sort of licenses or anything. Everything that we are using in CODA is open source and can be easily adjusted and tweaked to answer the needs in the specific countries. Those are the lessons learned from South Sudan. With this, I would like to hand back to Tav. Thank you.
Hi, thanks, Mohammed. I think I'll be, Tav, I'm just going to come and drive the final message home. So I'm Hajra Hafizur Rahman. I lead the Monitoring, Evaluation, Research, Learning, and Digital Innovations team in World Food Programme headquarters. So I'll be walking you through the next 3 slides through the broader, to describe the broader vision and journey of CODA. So with CODA, next slide, please. Sorry, Miriam. Thanks. So with CODA, we're not just digitizing a program, we're building a pathway towards something much larger, a digital public good. You must have heard it, Linda saying it, Kasi saying it, Mohammed saying it. So when we talk about CODA becoming a digital public good, we mean something that is open to use by everybody, open source, designed to serve the user interest. And for us, the users are the health workers and the country offices and the field offices. And it is adaptable by any government or organization anywhere. And I'm also seeing the chat coming through and some of the question coming through as well, right? And our message is that CODA is built for interoperability, not to operate in isolation, but to connect. And now more so with funding cuts, all of the nutrition communities present here, it's more evident that we need to partner more together. So we fully recognize the momentum and need across the nutrition, health, community partners and agencies to digitize service delivery. And this is why our focus is on complementarity and not duplication. And I just want to say, you've heard from Mohammed, we're in Ethiopia, we're in Nigeria. Just last week, we deployed in Ethiopia. But I do want to mention that deploying digital solutions at scale, it takes major investment and deep systems work. It has taken millions, many years. And the last thing partners and government needs is fragmentations. And CODA's open source design and government-led model, it makes it a strong solution for alignment with other platforms as well, especially in high burden settings we're talking about. So just to say that we're actively working for our longer term vision and roadmap to work with partners to map shared standards, integrate where it's feasible, and also reduce parallel efforts as well. So again, the points listed in the slides are also, right, that our starting point is simple and powerful. We want to enable easy and near real-time access to data. We've made it possible through open source technology approach. And this vision also goes beyond nutrition, where already we're seeing how CODA can support community health and social protection, where we're also managing vouchers and cash to track support for pregnant women and young children and vulnerable households. And at its core, it's all about tracking individual beneficiary, right? Enabling person level tracking, case management. So while CODA 2.0 is a milestone, the road ahead for us is even more ambitious. And it's fully scalable, country-led, and one that empowers communities, strengthens systems, and also goes far beyond the boundary of one program itself. Next slide, please. So in WFP, we work, of course, across different teams. We have a nutrition team, we have tech teams, but we also have an innovation accelerator who work with technologies like CODA and others to develop a human-centered design pathway to scale. And this is exactly what CODA has done. We have our CODA scale-up strategy and until 2030. And just to say that our long-term pathway to 2030, it's not just about numbers of countries, but it is about creating an ecosystem where countries can lead, they can adapt, and they can also own CODA as a solution for individual beneficiary management and ultimately stronger systems as well, right? So by 2030, we envision CODA reaching 50 aspirational countries, 15 of those prioritized for strategic investment, high burden, tailored support. Our ambition is for at least 5 countries to reach full scale, like South Sudan is, meaning CODA is used to manage over 60% of the caseload. That's what we mean by scale. And that's already underway in South Sudan, as you can see. And zooming into what's ahead for the next 2 years, in 2025, now we plan to deploy CODA in 3 countries, scale it in 1, already happening in South Sudan, 2 where strong foundations already exist. That's Ethiopia and Nigeria for you. So that also means that with that vision, we'll also focus on costing and resource mobilization to make sure that country teams are equipped with not just technology, but the resources to build capacity, scale, and sustain this as well. And at the same time, as you saw, that learning is generating learning and facilitating learning is so important. So socializing learning across the countries and then helping them exchange lessons and understanding how CODA can be adapted to different operational realities as well. Next slide, please. So this is my last slide, and I was excited, our team was excited that we're presenting it to the Global Nutrition Cluster. We all are doing similar work. So this slide really brings together the core message and the final message that CODA is not just a tool, it's a collective opportunity for all of us to transform nutrition service delivery. First, we've proven that CODA works. It reduces costs, it saves times, it improves quality of care. And the next step is systems change, embedding it into DHIS2 and how it becomes part of how services are delivered at scale. Our biggest learning has been that no single actor can do this alone. WFP cannot do this alone. And partnerships for us are the engine of scale for this. We've seen in South Sudan, Mohammed has mentioned all the number of actors we've been working with. So government, implementing partners, UN agencies, donors, they all have a role to play. And this shared ownership is what will make CODA resilient and scalable. And this is also about smart investment, right? You've seen how it saves cost, how it's efficient. So how CODA delivers result with the right support, it can be a game changer for digital transformation. And this is why we need to invest what delivers. And finally, beyond CODA itself, right, we will be looking at broader ecosystem, making it a digital public good, stock management, social protection. So we build systems that talk to each other and not duplicate. And CODA has already done that. And finally, the road ahead is that by 2026, our goal is to scale CODA to more countries, deeper integration with government, and generate global learning and a solution that not just benefits WFP, but the whole nutrition sector. So we're inviting partners to collaborate at a country office level and help shape us what comes next. So yeah, over from our side, and I think we can open it up for Q&A. Thanks.
Well, thank you so much to our presenters for, I think, an interesting piece of a bigger work that's being done in terms of the different activities and developments that are coming up with the nutrition programming. I see there's quite a lot of questions that have been posted in the chat box and in the Q&A, and I'd like to reiterate, if possible, if you could transplant your question that's in the chat and put it in the Q&A so that we can be able to go through the session in a more, I think, efficient and effective way. With that in mind, I would say perhaps I can go to some of the first questions when I pop into the Q&A. So for those who want to know the Q&A box, navigate to the bottom of your screen. It should be next to the globe. We've had quite a lot of questions and some have already been answered. So I think what would be a good one is to perhaps start with, let's see. I think let me go to some that have been answered so far, and then I'll read them and also read out the answer for the translation as well. So from Nala Rafa, the question goes, thank you for the webinar. How does this differ from DHIS 2? To which Mohammed responded, CODA is specific to nutrition and has additional features that are not in DHIS. However, CODA is interoperable with DHIS 2 to ensure that quality data is moved to it. So I hope that fully answers that question, but if you should have more follow-ups, please also feel free to intervene or ask follow-up questions. Then still from Nala, once again, we had another one on, can CODA be integrated into existing data collection systems to which Linda had responded, but I think this response could be in relation to a different question. So for that one, I'll skip and come back to that one. So maybe we'll go back to the open ones and have an intervention from the team. Let's see, which one can we ask? Okay, so we have one from Aidan Mohammed Ali, which goes, is CODA comprehensively covering all CMAM components like OTP, TSFP, and SC, or is it partially? Because during your presentation, you only highlighted OTP, TSFP, including preventions only. So Hajra, I see your hand is up, so I guess you'll take that
Yeah,
one.
sorry, my hand was up not for this question. I think Kasi or Mohammed will take it, but my hand was up for the DHIS2 question. And it's an important one, right? Because we get this question often, and we're also communicating closely with the DHIS2 it headquarters in University of Oslo in Norway as well. But then we've kind of mapped clear differences between the two, right? CODA is built for individual case management, whereas DHIS2 is primarily facility or population level reporting system. CODA, as you saw, it is designed as a job aid, means it supports decision making in real time, it's offline, it helps health workers follow protocols, input data, delivery services on spot, whereas DHIS2 is more focused on reporting upwards, used by data managers, supervisors. It's similar in terms of it also focuses on performance, trends, etc. And then I think there's also a difference between data depth between the two solutions as well, where CODA stores and protects individual data, like Kasi mentioned, personal history, biometric identification, tailored services, and DHIS2 is more on aggregated matrix here, which are essential for system-wide monitoring, but the granularity of individual level data that's what's coming from CODA. I said, right, like we've had conversation with the DHIS2 folks in University of Oslo, whereas there's this here understanding that CODA is built to complement systems like DHIS2, not to replace them. For example, CODA can feed clean, validated data into DHIS2 for national reporting, while it maintains its case management role as well. So I just wanted to mention that because I saw a lot of questions coming, and that's one of the most top questions we get usually as well. And then the question you ask, I'll give the floor to Kasi or Mohammed to answer. Over.
Thank you so much. Yeah, Hajra. And quite frankly, most of the questions are centered around existing systems like what you have in like in Somalia, and then and CODA, what are the kind of gaps we aim to fill? Is there a plan to harmonize these solutions and so on and so forth? I think the follow-up question kind of clarifies a lot of it, right? We need to minimize the information silos and then the many digital solutions that are out there. And so what will happen is that there is definitely an ongoing discussion with other stakeholders about unifying systems. That is why system interoperability, integration are very important. You know, we have different solutions in different countries. I've seen particular mention of a solution in Somalia, and then MODA, right? Quite frankly, our team is not very familiar with the solution that has been rolled out in Somalia. But if ever there is a reason or there is an interest from the country to implement CODA, of course we'll engage. We'll see where gaps are and how we can harmonize the systems there. CODA is system agnostic. System agnostic means that it can work with any other system, interoperate with that system. So assuming that the system collects data. And the point we want to emphasize is there are obviously strengths and weaknesses of all these systems. And to have a more unified data ecosystem is to have systems talk to each other. Systems that have been developed with every single user in mind, and so including government. So that's why CODA that was redeveloped is system agnostic. Every single Android device can use it that has NFC technology, and then also encompasses all the programs that we have, from wasting management for children under 6 months to prevention, OTP. Some for ITP and SC, we are yet to configure that, right? So but referrals between the SCs and then the mainstream wasting management programs have been incorporated inside CODA to ensure that we do not lose any beneficiary in this linkage. So what we're simply saying is that the idea is to have these systems talk to each other, not replace each other, enhance and strengthen existing systems. That is the goal of CODA. If you look at the UN80 mission that is currently ongoing, it's about having one unified system for all UN agencies that is technologically meeting all the highest standards. For example, CODA has had an ATO assessment, which is called the authorization to operate, and then the DevSecOps assessment that has also all by the UNICC, United Nations computing agencies, right? So they've done all the background assessment, risk assessment and everything. So, because we are collecting very sensitive data of beneficiaries. And if you look at the encryption, the data is encrypted at rest, meaning when it is stored in the cloud, data when it is in transition, when it is being transferred from the devices to the cloud is encrypted. When it is stored on the devices, the data is encrypted. And when the data is logically, in a way, disaggregated. So you cannot actually even identify one particular beneficiary by just one single aspect of the data, right? So there are very stringent data protection safeguards that have been put into CODA. We have the temporary authorization to operate from the UNICC. You don't have solutions like that, So we have followed very rigorous processes on our way to becoming a digital public good. So to assure you that we are willing to work with all systems, all agencies, to have a solution that works for everyone. So that's just to collectively respond to some of the questions that are flowing around whether CODA and DHIS2 or GO or MODA and so on and so forth. This is the reason. Country-specific solutions have been developed, but CODA is a global solution that aims to work for everyone in every context. Okay, back to you, Tav.
Thanks, Kasi, for that intervention. There is quite a lot happening in the chat box, but I also wanted to take a moment to bring it back to the floor to be like, is there anyone who would like to maybe ask their question, come in as well, so we can also have a conversation, see your face? Any takers?
So Tav, before anyone, I think there's a question on prevention, like what we are including in prevention. Okay. So prevention is a very, very complex aspect of nutrition management. You have programs that are preventing stunting, some are preventing wasting, and so on and so forth. And depending on the context, the modality and delivery platforms differ, depending on where you're going. But prevention in the treatment programs, what we are trying to do is have, for example, individual counseling sessions, group counseling sessions, including nutrition education sessions. What we want to do, as well as linkages to other prevention programs, right? Or other programs to prevent malnutrition and relapse. What we are doing inside CODA is that we want the algorithm inside CODA to learn the treatment history of a beneficiary and symptoms that they are presenting, so that at the assistance step, CODA can say that this beneficiary presented with, let's say, diarrhea, or the child has breastfeeding difficulties, okay? So CODA will prescribe the specific type of counseling that is required for this caregiver. So we are trying to prevent the situation where sometimes it is very difficult for health service providers or health extension workers to look through registers, look at the treatment history, or even not do proper examination and just provide blanket messaging or counseling. So we want to really target this. So we are taking our time to really build a solution that works, in this particular way, learning from a beneficiary's treatment history, their weight gain, the kind of assistance they have gotten. For example, I mentioned SBCC, right? So depending on the support or counseling that a beneficiary received from the beginning, we can track whether it has impact, whether whatever prompted that kind of counseling to be provided is improving or changing in any specific manner. Otherwise, another intervention is then prescribed. So we are also using it for cash, especially in Ethiopia here. They are providing voucher for treatment interventions. They are providing cash for treatment interventions. So what we are trying to do now is actually look at the financial service provider solutions or systems with WFP systems for beneficiary case management, where we can then integrate the systems to provide this kind of solution, ensuring that we prevent abuse of the system and diversion of aid and so on and so forth in terms of cash and voucher. There is a lot to talk about, right? But what we will do is that where there is specific cases for counter officers and interventions and everything, we'll have a more elaborate demo videos for everyone to be able to look at. Today's time wouldn't really allow us to go into details and then display some of these things. And some of the things that I've mentioned are also still in the works. So the prevention is very, very location specific, context specific. But what is cross-cutting is the messaging, counseling, and then the SBCC. Over.
Thanks for that. Thanks for that intervention, Kasi. My office still stands. If we could have someone from the audience who would like to actually intervene and ask their question, come online on screen. Any takers? Do I see any hands up? Let me see. Okay. We have 2 hands up. So I think the first one I saw was, oh, okay. It's gone down. Okay. Tiyani Buka, I don't know if I'm saying that correctly. Please feel free to come on. Tiana, I'm not sure if you're saying anything. You're still muted. Okay, now you're.
Hello, good afternoon, everyone. Thank you very much for the wonderful presentation for the indeed it to an innovative um, and inclusive innovation, especially if the movement aspect. Um, Actually, my question here is with regard to, let's say, the use of CODA. Since you have said that it helps in, let's say, prescribing intervention for beneficiaries. Does it use context specific? Maybe, we have cultural sensitivity, cultural differences in some of our areas of intervention. Does it put that in consideration? And then secondly, the use of catch voucher assistance, that's CVA, it also have in that. Does it have any algorithm or standard that is used in calculating that CVA? Because maybe in Nigeria, the cost of inflation in Ethiopia, and then let's say the cost of a specific balanced diet, maybe the cost that I may use to maybe, let's say, to formulate a balanced diet in Nigeria may be different from that in Ethiopia or South Sudan. Does it use that, let's say, uh, um, let's say, context specific or cultural sensitivity, and then the food available in that, let's say, context or region in prescribing, let's say, such interventions? And then finally, my question is with regard stabilization center. I would like it to be integrated into that stabilization center management, because it will help in adherence to protocol, as you said, in management situation, less especially with the milk. As you know, we have different categories of patients. Of importance is those with reductive adaptability, those that are severely wasted. Sometimes you have to start an upgrade treatment for them. You don't have to start with the required amount of, let's say, you have to start in early thought. That's more little by little for their body to adapt. So that these are just my own suggestions. Thank you.
Thanks so much, Tian, for your questions. I think some of them, your sound was coming in and out, but I did catch the gist of the first two, where you were echoing the same sentiments brought up in the chat about cultural preferences and cultural sensitivity, and also context-specific considerations within CODA. That can CODA, and how can CODA be adapted to local contexts, and how does CODA adapt to them? To make sure I got your question correctly, which is also what Rafi P asked. So from our panelists, any takers for that one?
Yes, Tav. I can quickly say to that first question that CODA, we follow the user-centered design approach, which means that however the users or the country context or the country wants CODA, it is how it is going to be. So all the cultural sensitivities are things that, of course, we would take into account. For example, language, right? It is pretty tricky, to have one flat language for the entire country. Maybe it's if you go with English and French, etc., right? But there are still some end users who are not very fluent in neither of these languages, so or national languages. So what we're trying to do is, based on the guidance of the country, we can adapt the solution to the language of preference for the country. And then, of course, the sensitive nature of some of the questions, for example, pregnancy question, and then also other sensitive questions that we need to consider that are essential to provide the tailored nutrition services required. The most important thing also is consent, right? If at any point in time, someone for cultural reasons feel that they cannot allow CODA to take their data, they have the option to opt out of CODA, but will still receive their nutrition services. So this is the very first thing that we consider. So there are definitely very important cultural considerations. That hinges on the user or the country's requirement. So we don't just implement CODA flat across board. No, it has to be customized to the context that we are implementing. Over.
Thank you for that,
Tav.
Cassie.
Okay.
No, thank you for that one, Cassie. Okay, I see there's still more hands up, so perhaps I can maybe go to Mohammed, because I'm not sure if you want to answer one or like add to another. So Mohammed, and then I'll go to another hand in the chat.
Thank you, Tav. So I'm just seeing some repeated questions on which programs CODA covers, and I would like to mention this to answer this question. So in South Sudan, CODA covers both the OTP and TSFP. OTP is actually a UNICEF program, and TSFP is WFP mandate. So children in both programs can be enrolled in CODA. And actually this sort of programming was a result of close coordination and collaboration between UNICEF and WFP to ensure that we have the continuity of care. So people within CODA, they can move between OTP, some treatment OTP and TSFP, between the two programs. It's one system built in one device. They don't need to split any register or anything. So that integration there was there by design from the beginning. Thank you.
Okay, thank you for that intervention, Mohammed. There are a couple of questions also in the chat around the I think there's one on the investment budget, and then another one on partnership. So I'll touch that and I'll come back onto the audience floor. So maybe we can just quickly touch on that one, since that would be a key consideration into this. That it's from Sarah Luzangi, and she asked, what exactly determines the investment budget? Is it population size or customized based on country office need, or both? So I don't know, Kasi, would that be you coming in on that one?
Sorry, can you ask that question again?
The question goes, what exactly determines the investment budget? Is it population size or customization based on the country office need, or both?
I would say that both, right? It depends on the size of the programs you want to incorporate. But again, we are making it an open source solution, which means that the source codes would be available if they are open, you know. Then it also depends. For example, if you want to incorporate other things that are not there, and then maybe have other specific features you want to onboard that currently do not exist in the system. So the cost of development might be something that would take this into consideration. Now, in terms of the population size, this also informs exactly the number of health facilities that you want to onboard, right? So we're talking about the capital investment around equipment, devices, and then NFC cards. So CODA uses devices, minimum 2 devices per site, and then NFC cards that are reusable upon discharge of a beneficiary. You just take the card, wipe the card, and then you give it to another beneficiary, and so on and so forth. So it's not one card per beneficiary, for life. It's reusable. So the investment will be basically development, and then this also on the devices. Now we also have the data hosting. Hosting the data in the AWS server. I think I posted this. We host the data in the AWS server where it is encrypted. So you need to pay for maintenance of this data, hosting of this data in the cloud also, which is very minimal, depending on the number of the caseload, hence the size of the data in the cloud. Does this answer the question? Over.
Thanks, Kasi. Perhaps we can ask Sarah Luzangi if you're still online. Did you have any follow-up questions on this one, or it's okay? I'll take that as a thumbs up for now. Jacinta, okay, I see you have a couple of questions in the Q&A, so would love to have you intervene. So please, when you're ready.
Can you hear me?
Yes, loud and clear.
Yeah. So first of all, thank you very much for this presentation. I understand that for the webinar today, it's a broader understanding of CODA, and I hope there will be other targeted series of CODA, because I'm just looking at if we need to adapt CODA. So there are several digital solutions over the years being developed. And of course, most of them have demonstrated efficiency, cost reduction. But if you can expand a little bit on what are the other, advantages of CODA beyond efficiency and the cost. Because if I have to advise, let's say, a sector or a government among several digital solutions, what are those elements? I think it didn't come out clearly, but if this will be covered in other sessions, that's okay. I still do not get clearly the service points or the other components that are included apart from treatment, SAM, MAM, and I understand that supplies will be added. Because for us, we really need, because most of the digital solutions that have been developed are looking at treatment, some but we need to go beyond that. We need to know how many contacts of counseling a child who is malnourished have received. Have they received vitamin A? Did the mother receive IFA? So that continuum of care, I think, will be more beneficial. So from where it has been tested, I think most of it is Sam and Mom. So maybe if you can expand a little bit on what are your plans for expanding it beyond that? I mean, nutrition have almost 10 high impact interventions. In an emergency, these are different service points. How do we use CODA in that context? Also, it will have been very useful because I understand government in Sudan have been involved for us to hear the government perspective or what is the experience, because all the solutions need to be led by government. So those, I think, my general questions. Some of them have been answered along the way. Thank you.
Yeah, Tab, I think I'll just take this if I hopefully
Yes,
Jacinta,
please.
I get all your questions. So to start with, quite frankly, it is difficult to keep track of the other digital solutions that are out there and to be able to do a proper blow by blow comparison or side by side comparison of CODA in these solutions. So if I am to do, I may only speak to CODA more effectively. Just to recount, the CODA has a basic package, and this is what we talked about, right? The basic package involves the fact that CODA is just not a solution that we are cooking from somewhere and we are going to deliver to anywhere. So wherever we are taking it, there'll be a very rigorous discovery phase where we engage with that country office to understand what their requirements are. So if it covers all these things that you're talking about, we will decompose that for the developers to incorporate into CODA such that it meets your requirements. So that would be my broadest, response to that. But not just the WFP office in that country, of course. It'll be with all stakeholders involved, from government to UNICEF, and where there is a cluster, we will engage the cluster, and then other NGOs within that country office to implement that. So that is how the process goes. And most importantly, we take into account some of these. We don't do anything that is outside of the country protocol. Now, on your question on how expansive or CODA is, it does have a very detailed clinical assessment questions, right? We test for appetite test, and where the beneficiary fails appetite test, we take the necessary action, right, to refer the beneficiary. We do edema, we do vaccination, we do vitamin A, we have deworming, we have malaria testing. Why there's no malaria testing, then treatment, the type of treatment provided, the IMCI danger signs, the complications, and the necessary action for the complications, and then vitamin A, age-specific vaccination questions, a whole lot is inside CODA already. So not to worry at all. And to tell you again, if there is any gap from what we have and your context before implementation, that would be addressed before implementation. And so I hope that I have responded to your question. Over.
Am I still on?
Yes.
Thank you very much for your response.
Thank you, Jacinta, for your question.
Thanks, Kasi. And if I can also just come in just for a minute to talk about the comparative advantage here, right? We've done comparisons of different sorts, really looked across the board. We've had market solution assessments from private sector solution that exist. UN agency solutions or NGO solutions which offer something similar to CODA, and watching how other tools are also positioning themselves. And of course, based on that, the gaps the other solutions had, that's what CODA was also built on, right? So we've done cost effectiveness reviews, we've done security reviews, we've done market solution assessment reviews, and this has been independent reviews as well, right? Not just WFP. And many of the findings of the reviews have been that it's one of the most advanced systems in terms of what it can do actually for the program digitization. So how it digitizes full delivery chain across nutrition, health, stock management, a voucher digitization as well, but also cost effectiveness as well. We've done cost comparisons through site, and how it's reducing wait times, how it's saving money, and how it's also improving how services are delivered. Security wise as well, we've done an independent security assessment as well. I've seen a lot of security questions coming up, and just to say that for WFP and tech, the standards and the security standards the organization follows are non-negotiable, and one of the most stricter ones as well, where and also one of the most stronger one. And recently, CODA has passed the UNICC authorization to operate the review. We went through full DevSecOps assessment. These are all technical terms, right? But just to say in simple terms that it uses top grade protection, encryption, firewalls, secure access, all of it as well, right? So, and that's a big deal when you're working with personal sensitive data as well. So if that also answers your question, Jacinta, as well. And prevention, like Kasi mentioned, it's more complex, right? Because treatment, OTP, TSFP, it is kind of standardized across the board if we look at a lot of the high burden countries as well, but prevention looks very different for all NGOs, for all agencies. So for us, it depends on how the program is designed, but CODA is absolutely now working on building around that too in the same countries. And it just depends on what's being prioritized by the country and what the prevention model look like. But given that it's not a one fixed model approach, it's about flexibility. So CODA has that foundation to adapt and be flexible as to what the program looks like. Over.
Thanks so much, everyone, for your interventions. I know you just saw like a pop-up of the interface. We'd hoped to have an opportunity to maybe do a quick demo with everyone, since that also was a key question, but unfortunately we're a bit strapped for time. We have only 3 minutes left on the clock. So I would say I think we'll look for opportunities to also share a demo. So I think you can see not just the presentation of the platform, but to actually experience the platform itself. If you are in a country where there's a WFP office, also please feel free to reach out, and then we can also coordinate from that point. So now as we close, I just want to give everyone a big thank you. Thank you so much for sticking with us. It has been our absolute pleasure. My apologies we couldn't get to all the questions, but we will forward them to our panelists and have them respond, and also share those responses with you. Gentle reminder that this session is being recorded. So in the coming days, you'll see the recording and the slides also being updated or uploaded onto the GNC website. So stay on track for that one. And before you go, would really appreciate if you'd maybe take a moment to complete a short evaluation form. I think that will be shared with you. Your feedback would really help us improve future webinars, ensure we continuously make sure we're actually meeting the needs that you have in terms of this knowledge sharing experience. So with 1 minute left on the clock, it is a big thank you once again for joining us, and also for the work you do every single day to strengthen our collaborative effort in nutrition programming. I wish you all a wonderful morning, evening, or afternoon, depending where you're joining us from, and we hope to see you next time. Goodbye.